Okay, welcome everyone to this spotlight on automated insulin delivery in pregnancy. You're not here to listen to pregnancy, this is your opportunity to escape. If you are here to listen, we're delighted to share with you some of the really groundbreaking revolutions we've seen in the diabetes technology space in over the recent years. So my name is Helen Murphy and I am a clinical scientist, been working in this space for about 20 years now. These are my disclosures. I will stress that all of our research is independently funded, and whilst we receive device support, sensors often at reduced or at a research cost from various technology companies, we remain device agnostic. At every stage in our work, we choose the best technology solution for the right population of women at the right time. For those who are not so familiar with working in pregnancy, 1 in 2 women will still have large for gestational age babies. These large babies are very often delivered preterm. They are much more likely to be admitted to neonatal intensive care units. For the mums, they're associated with birth injuries, and birth injuries is the leading cause of medical legal litigation in the UK, taking up more than 4 times the entire maternity healthcare budget. So anything we can do to reduce the risk of large babies, to reduce the rate of birth injuries, will allow us to spend more money on care. And over the longer term, it will reduce these babies' risks for the life course problems with obesity, cardiovascular disease, type 2 diabetes, and increasingly recognized neurocognitive disorders. Aiming for tight glucose levels in pregnancy is absolutely crucial for to minimize the risk of obstetric and neonatal complications, and the pregnancy glucose targets therefore are much tighter than targets outside of pregnancy. 70% time in the non-pregnant range equates to only 45 to 50% in the pregnancy range. This is an order of magnitude difference that is really challenging to achieve. And over the last 15 years, we've been working closely with engineers, Roman Havorka in Cambridge, to develop pregnancy-specific algorithms that are fit for the gestational challenges of pregnancy. Here at the EASD last year, we published our pivotal trial called the ADAPT trial that gave unequivocal evidence that women who use pregnancy-specific hybrid closed loop are much more likely to achieve the pregnancy glucose targets. Specifically, they achieved a 10.5 percentage point increase in time spent in the pregnancy target range. They did that very, very quickly, within days, such that by the end of the first trimester, there is a clear day and night difference between those who are using standard insulin delivery with real-time CGM compared to those using automated insulin delivery, and that difference persists right across pregnancy. You'll see that the difference is also there right across the 24-hour day. So whilst the maternal mothers spend much more time in target overnight, this is not a system that just gives a little bit of extra overnight. It works over the 24 hours, and that is because of this uniquely adaptive algorithm. This is also not a system that just benefits some women. This is a system that works across all women, regardless of the baseline glycemia. So the treatment effect, that 10.5 percentage point increase, is equally applicable to mums with HbA1cs between 6 and 7%, to those between 7 and 8%, and those with 8% and above. This means that this is a system that is applicable for a nationwide implementation, not just a system that can be used in selected women by selected centres. It's also a system that works equally well for women with previous device experience and those with none. Half of the study participants used insulin pumps, half of them used multiple daily injections, and a small number used other AID systems. In addition to those clear benefits for maternal glucose that lasted from the first trimester through to delivery, women had remarkable quality of life benefits. And for those of you who have type 1 diabetes, it is worth reading those papers. For those of you who remain unconvinced about the difference this can make to the lived experience of women with type 1, or those of you that think it's too hard to do something new in your already busy clinic, please read the qualitative papers. Offering women the opportunity to improve the health and well-being of themselves and their babies is an enormous privilege, and no one should be too busy to offer high-quality care to pregnant women. Some of the additional biomedical benefits that were unexpected is that women gained less gestational weight, 3.7 kilos less gestational weight, because the insulin delivery was more targeted and precise. That's about 8 pounds and 8 ounces. Now that comes with real health benefits for the mum and for the baby. It also came with a lower risk of gestational hypertension and some of the lowest rates of large gestational age babies and neonatal intensive care units admissions that we have ever seen in a representative population of women with type 1 diabetes. It was on the basis of the ADAPT trial results and within 3 months of the primary publication that the NICE Guideline Committee produced what we call a technical appraisal recommending hybrid closed loop as the treatment of choice for all pregnant women with type 1 diabetes. And you may see that increasingly other hybrid closed loop systems may be used with very good effect outside of pregnancy. And we believe it's quite safe for women getting pregnant on other systems. Those other systems target 3.9 to 10. They were not designed for pregnant women. They do not have a background of 15 years of research, tweaking them and checking them against all of the gestational challenges. So if you read the results of these 2 pivotal randomized trials, one using the pregnancy-specific CamAPS system, the other using the very well-established Medtronic 780G system, you'll see that the ADAPT trial incorporated a very broad patient population, 124 women, aged 19 to 44 years, BMIs between 18 and 49, HbA1cs at entry between 6 and 14%, half of them using MDI, and an independently peer-reviewed study funded by our National Institute for Health Research. On the Medtronic side, the Belgian study predominantly led in Belgium. 96% of participants were existing pump users. Women were aged 30. They had far lower BMIs, and they had a mean A1C of 6.5%. Now, remember, I just told you that the participants in the ADAPT trial with A1Cs between 6 and 7% still had a 10.5 percentage point improvement. Unfortunately, the women who continued using the Medtronic 780G, despite their excellent baseline glycemia, had no improvement above and beyond what you would expect from a pump and a sensor alone. So there was no additional gain for using this during pregnancy. There was absolutely no harm in using it until the time of the first trimester, because it is a system that can well target 3.9 to 10, but it's not a system that adapts to the gestational challenges of pregnancy. And we've seen recently some real-world data from Spain, from a group of people with no skin in this game, I would say, who outside of pregnancy compared all of the hybrid closed-loop systems and found no significant differences. So if you're targeting the 3.9 to 10, it really doesn't matter if you use the Medtronic 780G or the Tandem. It can come down to patient and clinician choice. But when it comes to pregnancy, take a close look at the results of these 2 studies. So using the pregnancy-specific CamAPS system, 1 in 2 women achieved the pregnancy glucose targets from 16 weeks gestation until delivery. The women who did that had 3.7 kilos, or 8 pounds, 8 ounces, less gestational weight gain, and an LGA rate of 39%. The participants using these other systems, and if we look at those, especially at the participants with HbA1cs of 6.5% and above, only 5% achieved the pregnancy glucose targets. They achieved it with increased gestational weight gain. On average, 3.3 kilos, but for those who entered pregnancy with HbA1cs of 6.5 and above, that was 5.4 kilograms. Now, you can do the maths and add 5.4 and 3.7 and begin to think of what a difference that will make for these women and the babies. The LGA rate on the other systems was 69%, and that speaks for itself. So if you work in pregnancy and you want to use a system that's going to give women the best chance of achieving the glucose targets with the lowest risk of large babies, there is at the moment only one choice. The other systems do get there, but they do not get there until right at the very end of pregnancy, much as we saw in our concept study of CGM alone. So they will get to the pregnancy range, but they don't do it until 32 to 36 weeks. And that is too little, too late to improve mother and baby outcomes. So, in summary, we have a system for the first time, a pregnancy-specific system, which we define as a system that has a license for use in pregnancy, a system with a glucose target of less than or equal to 5.0 millimoles per litre, or 90 milligrams per deciliter in US units, and a system that must surely offer women the minimum of 5 percentage point improvement, not a system that offers them nothing above and beyond a CGM and a pump. And this again summarizes some of the additional benefits for mums and babies. Less weight gain compared to other systems, and babies who also have less weight gain compared to commercially available hybrid closed-loop systems that have not yet been refined for pregnancy. So across the UK, in all maternity clinics, of which I believe there are 184, we will be issuing strong clinical advice to women and to diabetes pregnancy teams that it is absolutely safe for women to enter pregnancy on any hybrid closed-loop system. And that will help many of them achieve the target of 6.5%. But what it will not do is help them adapt to the gestational changes of pregnancy, for which there is only one system with a glucose target low enough and a documented evidence of improved time and range in pregnancy. So we will be specifically stopping all other hybrid closed-loop systems and recommending that women take up the CamAPS pregnancy-specific system as soon as possible in pregnancy, and of course, ideally, even before pregnancy. And you'll hear a lot about what we call politely barriers or perceived barriers. These are actually excuses. Patient choice. The woman likes the color of this pump. She doesn't want to have a tubing. Well, go tell her she might gain an extra 10 kilos and see whether she will be happy to have the tubing. Tell her she can continue the other system, but it will not reduce the harm for her baby. Ask her if she wants to have a large baby and she's willing to take the risk of a birth injury. I have not yet met a pregnant woman who doesn't want to do the best for her baby. These are excuses. An incompatible phone. Get over it. The cost of a phone compared to the cost of a birth injury is trivial, and we can work these things out. The biggest excuse is clinician inertia. And I would say to you, this is simply not good enough. If you believe in evidence-based medicine and you want to make a difference to the lives of women and babies, then you organize your teams and your systems to deliver high-quality, evidence-based, proactive, prepared care, and you overcome these non-barriers and excuses that get in the way of doing the right thing. And it's not difficult. Pilar will talk how to do it. Everything you need to know about how to do this can be summed up in very simple 5-minute videos. It doesn't take more effort for women, and it doesn't take more effort for diabetes pregnancy teams. Women using pregnancy-specific hybrid closed-loop had fewer visits, fewer contacts. Take-home messages: there is one pregnancy-specific hybrid closed-loop system that improves maternal glucose. It does it within days. It works during pregnancy. Actually, it works even better after pregnancy in the postnatal setting. And we, all of us who work in pregnancy, need to start organizing care in a better, proactive, prepared way to ensure as many women as possible enter pregnancy on the system. Those who don't should start as soon as possible in pregnancy, and no one should ever take it away from them after pregnancy. Thank you for your attention. I just acknowledge the entire team who contributed this work over 15, 20 years.